Works. Got it.
It's easier.
All right. All right. Stefan Hartman here, Iron Direct Primary Care. And we have Dr. Douglas Harrington. He's going to be going through my PULS test results and telling us a little bit about the PULS test and how this can be important for my practice when I'm helping patients in the post-COVID state, either post-vaccine injury or long hauler COVID, how the PULS test can help with that, but also how it can help with general risk stratification for cardiac disease.
Okay, well, Stefan, it's nice to meet you electronically, and it gives me an opportunity to talk about the PULS test, which is very important in terms of evaluating the health of a patient. And it looks like we're going to go through your test personally, right?
Yeah, and tell us a little bit about that study that was shown there a second ago, where there was a little bit of a pushback against this study after it revealed that there was a lot of inflammation after the vaccinations.
Right. So, and there's nothing wrong with the study. It was just data. This is 566 patients that had both pre and post vaccination PULS scores, and the PULS score increased from 11 to 25% over a 2.5 month period post vaccination, and that's a real increase. It's not an artifact, and it makes sense because when you think about it, all the vaccines, it doesn't matter which one, create a functional spike protein, and the spike protein binds to a receptor called the ACE2 receptor, which the most dense population is found on your arteries. In other words, and in the smooth muscle of the arteries. And what it does is it gets internalized into the endothelial cell. Those are the cells that make up the single cell layer lining of your arteries. And it actually interferes with DNA repair, and it creates a transient immune response, which is what the vaccines are supposed to do. And we know that there have been reports of blood clots, strokes, heart attacks post-vaccination, and also post-COVID. It turns out that this is not an anti-vaccine result. This is just an example of where we know the vaccine is working, but it does temporarily increase your risk. And as long as you don't have comorbidities like diabetes, obesity, cancer, immune problems, metabolic problems, you're probably going to be okay. But it's important for healthcare providers to know that this is a real risk. It does exist. Now, when you compare it to what happens when you get COVID, COVID takes you up 50 to 100%, not 11 to 25, but 50 to 100%. And the risk is dramatically more when you get the actual infection, especially in those individuals with comorbidities like obesity and diabetes. And there's a reason for that. People that have insulin resistance, like metabolic syndrome people, these are people that may be obese, they may have high blood pressure, low HDL or good cholesterol, insulin resistance. The problem is that their arteries have a lining. It's called the glycocalyx. It protects the cell layer that's the main lining of the arteries. The glycocalyx in these individuals is a third the size it normally is on average in normal people. And they're also in diabetics or bare patches. And what that means is the lining of your arteries is more prone to damage from either infectious agents or free radicals. So that's really what this study showed. It's not unexpected. The PULS test itself measures vascular inflammation, okay? And it turns out that vascular inflammation is actually the pathology that's involved in coronary artery disease. So it's not really heart disease, it's artery disease, okay? And it's usually generalized. So that's why the PULS test is so important, because it's diagnostic of vascular inflammation. And then it allows us to categorize your residual risk, normal, borderline, or elevated. And then we have lookup tables with large numbers of patients where we compare your score to patients of your age and sex and ask how many of them had a heart attack or stroke in the next 5 years. And that's where we get the absolute risk score, which is the number that we put on the report. Okay, so that's it in a nutshell, Stefan.
Excellent. All right, let's get to my results here and can tell me if I'm dying or not.
Okay. Well, that's your expanded lipid profile. And okay, there you go. Now you need to go to, that's the last page. You need to go to the first page. There you go. Okay. Well, the good news is you're not even remotely close to dying. You are one of the 1% of the population that is actually, you know, very close to your expected score. On the top, you have a PULS score, and that's an absolute risk score. The most important statement on here is patient acute coronary syndrome profile is normal. And that's because the PULS test is specific for acute coronary syndromes and strokes, not the whole, you know, garbage bag of heart disease. And in your case, that PULS score means that patients of your age and sex with your score, a little over 1% had a heart attack or stroke in the next 5 years, but it means that 98.5% did not. So the odds are very much in your favor. Now, below that, you'll see an expected score. It's 1%, okay? That is for an individual who has no evidence of disease. They have no family history. They're not on any medications. They're not obese. They don't have high blood pressure. In other words, it's heavily weighted towards age and sex. And that comes from our NIH data. And what's interesting is that in order to put the PULS score in context, we want to give you what's called a relative risk. And what we do is we divide the PULS score by the expected score, and you're about 1.5 times expected. We get more concerned about that when you're 4 or 5 times higher. Usually 5 times greater is the cutoff. And then that puts you at low risk by AHA, ACC cardiovascular risk guidelines. And in an individual with your score, we would recommend this only be done once a year, annually. Now, if you were in the borderline region, you could do it in 4 to 6 months if you were going to implement a lifestyle or supplement program. And if you're in the elevated category, you need to do a deeper dive on the patient. But what we want to stress is that that is not a death sentence. That's a check engine light. And, you know, since this is a 5-year window, you have ample time to figure out what's the reason for that. And then below that, you see a bar graph. And in the simplest form, what we do with this is they're more green than red. And in your case, there's definitely more green bars than red bars, right?
Yeah.
But you'll notice that there is a 0 line, and the actual units on this are not picograms per milliliter. They're percent increase or decrease in predicted events based on the individual component that we're looking at from the algorithm. So they can add up to more than 100%. What the algorithm does is it takes all of these and it puts them into a formula that appropriately weights them and gives you the integrated score, which is the PULS score. So you don't want to treat the individual biomarkers because those are signals from your endothelium, the lining of your arteries, that it's been injured, okay? And almost everybody has some level of injury on a daily basis because your body's making hydroxyl radicals from the breakdown of red blood cells. You have a little oxidized LDL. If you have too much vitamin C without enough glutathione, vitamin C becomes a free radical. There's a lot of things that can do this. Infectious agents in particular, we've already seen that COVID does this. And you read this from right to left. And in your case, these numbers are not very high at all, even though the bars look high. There's absolutely nothing to worry about here. There's no evidence of acute processes going on. You look pretty darn good, okay?
Okay.
And then below that, there's a graph that summarizes everything, and it's color coded. You can see that 1.56 is green. If you were in the borderline region, it would be yellow. And if you were in the high region, it would be red. And then you see your expected score, and the score gap is actually the relative risk. And then there's the AHA, American Heart Association, American College of Cardiology guidelines recommendation in the bottom there. And that's that page, okay? Now let's go to page 2. These are the protein results. These are the actual signals from the endothelium. And what's important about this is, again, you want to see if there's more green than red. And number 2, you want to see if any of them are in the hundreds, okay? And technically, you only have one that's barely there, that's HGF, but it's not really high at all. But it's one we'll keep an eye on. HGF is usually cardioprotective. However, if it's above a certain level, it's 1,011 picograms per milliliter, it increases your stroke risk by 3 times, and there'll be a comment down below that will highlight that for you. It's automatic, okay? So you don't have to worry about, analyzing it. But everything else looks pretty good here. Now, if you go to the 3rd page, there you go, heart age. This one confuses people, so I want to spend a moment on this. Okay, this is an artificial construct. It's not a biological measure. And it's a very easy calculation. We always include this example on the report. It's for a 42-year-old female. You'll see that her expected score is 1.55%. And yet when we did her pulse score, it's 2.31%. So all we do with this is say, how old would you be to have that as your expected score? And she would be 47, so there's a 5-year gap there, okay? But since we're in a 5-year time frame, once you get above 50, the curve goes up real fast, and you'll see a lot of patients above 80 or around 80. The good news is that if you make slight improvements, it comes down real fast. So let me give you some context on this. The CDC and the NIH did 3 studies on heart age, and theirs was in a 10-year time frame. All 3 studies had the same result, which was 75%, or 3 out of every 4 North American individuals over the age of 30 have a heart age that's significantly older than their chronologic age. And it's predominantly due to lifestyle and modifiable risk factors like smoking or blood pressure. And so what we use this because it tends to be more impactful with patients. But they have to understand that they're in good company because 75% of their neighbors are in the same boat, and that's not our data. That's the NIH and the CDC. So we're in a 5-year time frame. So we have a lot more people going up fast, but they come down much faster. And really, you can address this by looking at lifestyle and modifiable risk factors like blood pressure, weight, that sort of thing. You can make this come down fairly quickly. Okay. Now, do you want to look at your expanded lipid profile too?
Yeah, I think that was the previous page.
There you go. Okay, so you're doing pretty good. There are some interesting things on here though. Your CRP is elevated. That's not cardiac. That's a generalized. It actually mostly comes from the liver. It's a great acute phase reactant. We use it to tell whether you've got some joint problems or you had a cold, or you may have even gotten the vaccine. I don't know. Do you know what happened around this time?
I was at the conference in Vegas. I remember I did have some Italian food the night before, and I was worried that may have triggered it.
Could be. But what's interesting is most of these things look pretty good. Look at your SD-LDL though, okay? Now, I don't know if you've ever heard my lecture on LDL, but LDL in and of itself is not bad. You need it for life. You need it for life. But if it gets glycated, it shrinks and becomes SD-LDL, which is the most dangerous form of LDL. It has the longest half-life. It's most likely to become oxidized. And there's 4 things that are major causes of SD-LDL. That's sugar, refined carbs, alcohol, and omega-6 oils. And I can tell from this, because you're in the high borderline region, that your diet wasn't perfect before you got the blood test, because you've definitely glycated your LDL, okay? And this is a great way to tell. I have a lot of people, most of my patients are doctors and nurses, and they always tell me they're doing everything right. And I look at their SD-LDL and I say, okay, not happening. It's not right. Like I had one lady, she said, I think it's probably alcohol because I like wine And I usually have 3 or 4 glasses a night. And I go, you realize that's a whole bottle. And for women, that's not a good thing. And I said, you need to cut back to 1. And she says, okay. And she took off of her desk this giant wine glass that had a big bowl in it and said, this will be my 1. So bottom line, when you see this, you need to go back and look at you need to do a nutritional assessment. And believe it or not, working on that will definitely lower the pulse score if you get it fixed. Okay.
All right.
So that's it.
Good. That's cool. I think we had Logan's profile here. I think I put hers up there. She got it around the same time that I did. She was basically eating the same thing. We're out in Vegas at the conference, probably having some alcohol, probably having some Italian pastas and stuff we normally don't do. Let's see what her.
Well, you have to do it once in a while. It's what you do all the time that actually harms you. So once in a while, no big deal. Okay. And it takes a little while for it to change. So you must have been partying. She's entirely normal. She's almost perfect. And her profile is very similar to yours. If you look at her, the only thing she has differently is a little bit of fast ligand. And she's low risk by all measures. Let's look at page 2. And she doesn't have anything in the hundreds. Her hemoglobin A1C is okay. Her HDL is fine. That's good. Let's look at her heart age. It should be close to where she should be. Yep, she's 28. That's fine. Now let's look at her expanded lipid profile. And she has the same SD-LDL issue, not quite as bad, and her HSCRP is up a little bit. And I can tell you, if you had some good Italian wine along with a lot of pasta, that explains a lot of this. Okay.
Yeah.
So I'd be willing to bet that since you got home and you've decreased all of this, that you're probably back to normal. And we can repeat this in a year, and just see what's going on. Okay.
Yeah, for sure. Yeah. So the HSCRP, compare this to like a previous CRP that maybe they've gotten a Quest or LabCorp. Is this like the same CRP or is this a high sensitivity? Explain that.
It's a high sensitivity CRP.
Yeah.
And just to give you an idea of how powerful the biomarkers from the pulse test are, if we just take the biomarkers and compare them to CRP, the biomarkers alone are 2.5 times more sensitive and specific than CRP. Okay. So, but then when you put the algorithm together, it's even more important. But CRP we like because it tells us that you have more generalized inflammation. In other words, this is not restricted to the artery lining. It's also, there's something else going on in your body. And things that do that are sugar, joints, exercise, too much exercise, things like that. Okay.
Cool. Great. This is great. And I see a lot of applications for my patients. I deal with, sometimes high performance athletes, bodybuilders, they're pushing their body to the max. I feel like this is a great test to give them idea, are they putting themselves at risk? That's a huge concern in the population.
Right. Yeah, there are so many athletes, especially extreme athletes, bodybuilders, people that do ultra marathons, people that do triathlons, Ironman competition, that actually have more plaque than sedentary people and are more at risk. It's like they say, everything moderation is a good approach to life. You know what I mean?
Yeah. And then where I'm also going to use this is in my long hauler patients. Going to see, are they still having endothelial damage? Is the medications that we're using, is it controlling it? So that's where I see it. No,
that's actually a really good use, because it's clear that long haulers have a smoldering endotheliopathy, because the main disease process in COVID is an endotheliopathy. That's an inflammation of the lining of the arteries. And that's why the lungs, the heart, the brain, the kidneys, the liver, they're the most affected by this, so it makes sense.
Precisely. Great. And I'll be ordering this test. So thanks for sharing this with me.
Yeah, and we're always available to help out with weird cases. You'll get some very strange cases once in a while. Okay. Yeah. All right.
Thanks.
Thank you, Dr. Harrington. Thank you, Mr. Harmon. I'll give you a call and get you set up and all that kind of good stuff. Okay.
Appreciate it.
And then
Thank you.
I'll send this to Ben, this recording, once it has to process. It'll take about a half hour, and then I'll try and get it out to you. Okay.
All right. Thanks, guys.
Okay. Bye-bye.
Thanks, everybody. Thank you. Bye-bye.